When it comes to process improvements and effective change management, hospital leaders must leverage actionable data, but where and how to gather that data is a challenge. In response to these barriers, hospitals and health systems are designating individuals and teams to effectively gather data on their robotics programs to benchmark and measure metrics strategically as their programs evolve and grow. I'm Molly Gamble, Vice President Editorial for Becker's Healthcare. Today, I'm privileged to spend some time with a dynamic panel to discuss navigating roadblocks to gathering data, change management initiatives within their institutions that are scaled throughout the health system, and leveraging outcomes for payer strategies. Before we dive into our discussion, let's learn more about each of our panelists today. John, can you begin and introduce yourself?
Hey, Molly. Thanks for having me today. My name is John Phillips. I'm president of Methodist Dallas Medical Center, part of the Methodist Health System in Dallas, Texas. We're a 592-bed hospital in downtown Dallas, Texas. Some of our crown jewels here, of course, of our robotics program. We have a teaching program, level 1 trauma, and also a liver, kidney, pancreas transplant program that are just a few of the highlights of what we do.
Thank you for being with us, John. Dr. Martin, can we move to you?
Sure. My name is Dr. Jackie Martin. I'm the Vice President of Surgical Services at Barnes Jewish Hospital in St. Louis, Missouri. We're part of the BJC Health System, a 15-hospital system affiliated with Washington University School of Medicine. We're a level 1 trauma center. We have a very busy transplant program. We train a lot of residents and fellows each year, and it's important for us to remain on the cutting edge.
Thanks for being here, Dr. Martin. And finally, Nancy.
Nancy Bowman, the Executive Director of the Colorectal Division within Texas Oncology. We have 30 colorectal surgeons within our private practice, which would make us the largest private practice of single specialty private practice colorectal specialists.
Well, as all of you just set the stage, you are leaders in healthcare, and I first wanted to establish a baseline to better understand what metrics are really the most important to you, and how have those metrics helped shape your system strategy? Is there a connectivity to overall cost, quality, and growth of your service line? John Phillips, let me turn first to you on this one.
Thank you, Molly. Yes, my background before getting into hospital leadership or health system leadership is physical therapy. So I went to UT Southwestern here in Dallas to physical therapy school. So they get the credit for really helping me, I think, shape a mindset of having a true north, when it comes to any service line or anything that we're trying to do within our health system or hospital, just staying true to certain principles that you believe in. And years ago, the Institute for Healthcare Improvement taught me about the triple aim. So my version of the triple aim is, number one, patient experience and quality. Of course, taking care of our communities, improving the health of our communities, and then cost. We've got to understand cost and make sure that what we're doing, whether it be a service line or whatever the initiative is, it's sustainable, that there's a reasonable cost associated with it as well. And there's ways that we can, dial down that cost if needed. And then we've added at Methodist the care of our providers. So I hear quadruple aim used now, and at Methodist, care of the provider, whether that's the physician, the nurse, the scrub tech, the therapist, the housekeeper, rounding out the triple aim to call the quadruple aim. So that's really our care commitments that we've now translated the quadruple aim to our care commitments. So everyone at our hospital understands that we look at metrics within those areas. And when it comes to robotic surgery and anything that we do from a minimally invasive surgery standpoint, what I hear our surgeons talk about and our nurses talk about is really making sure we're hitting key metrics in those categories. Provider experience with our robotic service line, making sure that the key quality metrics or patient outcome metrics that we're identifying those and improving upon those. And then, of course, it's just a reality, understanding cost associated with our robotics program are all areas that are interconnected, that, really over our robotics journey, we've gotten better at identifying, monitoring, and improving upon.
Well, John, you just described many metrics and objectives under that big umbrella of the quadruple aim. Dr. Martin, what metrics and what are you watching most at Barnes-Jewish, and what's shaping your strategy?
Yeah, Molly, great question. Again, many of the things that John mentioned, but for us, our approach has been to as we've added robotics, is to ensure that we're leveraging the value that robotics brings to our service line. And like other things, one of the questions is, as we move along this journey with robotics, how are we going to determine a year from now whether we're making progress or not around safety, quality, whatever. And therefore, we have a number of operational metrics. We have a number of clinical metrics, clinical outcome metrics. We have a number of financial metrics that we look at. And that helps bring the clinicians together. It helps bring executive team together. It helps sort of get everybody focused on the things that are going to be able to answer the questions about how well we're doing with our program. For example, an operational metric would be room turnover times. When we first started out on the robotic journey, our turnover times were about 45 minutes. Those are now down to about 20 minutes. And we've done that through actionable data. Financial metrics. We look at our INA costs, like I'm sure everybody else does. We look at our cost per case with robotics versus, and not only with robotics versus laparoscopic or open, but also between providers doing the same type of cases, so that we can leverage opportunities for more standardization where it makes sense. And then we have a number of clinical metrics that we measure. Things like length of stay, blood loss conversion rates, post-op infections, reoperation. So all of these metrics help us really sort of determine where we are on the journey, how we compare with other programs. And as well, what we've seen, for example, over the last 3 years is a decrease of about 10% in our open surgical procedures to MIS and primarily robotic, with a flattening of our laparoscopic. So no change in our laparoscopic cases, but 10% less open surgery and 10% more robotic surgery. So I think data, and analytics are important. Actionable data is more important. It helps bring us all together and helps sort of keep us all aligned in terms of where we're trying to take the program.
Yes, definitely. So we've heard from two hospital leaders and what they're keeping an eye on. Nancy, let's turn to you, because as you mentioned, you're managing a group practice. In your opening remarks, you said 30 physicians. What metrics and data points are you looking at?
Very similar to what obviously the two previous speakers have mentioned, especially Dr. Martin got into some of the specifics. But our group, we started collecting data probably, over 5 years, 6 years ago, in trying to differentiate for two purposes, really, how, what determines, a good colorectal surgeon. What would be the metrics that you would look at if you're going to evaluate one surgeon from the next? It wasn't specifically just surgical approach. There was a lot of other variables that went into that. So, and then from there, it has grown exponentially, where we collect some up to 600 or 700 data elements per surgical case at this point. But it includes a lot of the things that were previously mentioned with the unplanned events, like the readmissions, the reops, SSIs, conversions, and that sort of thing, the complications, also length of stay. But in addition to that, interoperative data that Intuitive is able to provide, whether it's instrumentation, turnaround time, the docking, undocking, draping, that sort of thing. And I also to claim myself as a data junkie. I think it's fun to look at the variability and the similarities, not only from hospital to hospital, but surgeon to surgeon. So now having 30 surgeons that are across probably that many hospitals across the state, we can look at the variations and identify best practices, whether it's interoperative or just within the patient care encounter itself within the hospital. We're also looking at pre and post-acute care metrics. So we're also looking at patient compliance. We have a digital application that we track and communicate with our patients as far as complying with the clinical pathways that we've developed that we feel like would optimize their outcome along the ERAS protocol. And then also post-acute, we know where our patients are going after they leave the hospital. Are they going home? Are they going to home health? And what that care path looks like. And then we're also capturing patient-reported outcomes as far as their quality of life, their activity, their pain level, because as our data has matured and gotten more robust over the years, our physicians are truly doing quality improvement of their own pathways and trying to identify within our own practice what is the best, most efficient, but then also it's yielding the best outcome as far as the patients are reporting. So it might be a little extra, an extra day in the hospital, an extra length of stay, but if it's going to reduce my readmissions, or if I'm getting them out quickly, we know that they're still, and we're trying to monitor or minimize or not even provide, opioids, the narcotics post-acute. We're going to, trying to educate and engage the patient. So monitor, there's a lot of things we're looking at pre, post, during the stay, as well as intraoperative to put it all together, which then goes back and also we look at the total cost of care. So we're looking at not only the intraoperative case costs, but then the encounter as well as the total event. So there's a lot of things variables we're trying to piece together.
Most definitely. Well, as you all illustrated, you are watching many pieces of data. Now let's talk about some of the challenges or roadblocks you face when it comes to how you obtained that data. And what does that access look like for you? Is it dashboards, decision support, business intelligence groups? Dr. Martin, let me turn to you first for your thoughts on this one.
So we're fortunate that we have a very robust internal PI and data analytics group. And so we have a lot of very, very good data. And we've evolved from just counting cases to really looking at how well the robotic resource is utilized in addition to the room utilization by a physician, by a procedure, for example. We also use the intuitive portal, and we use it as a reconciliation tool, if you will. And we look at the data coming out of that portal with our INAs, and we also look at our own data. And we find that to be very valuable in terms of reconciliation and helping answer a number of questions that we have around our program. One of the questions that came up is from our finance guys and our internal legal people is, are you sharing PHI and what's that look like? And we don't share PHI. And we've gone through a number of dialogues and discussions with the MACA group and with Intuitive. And we've convinced our folks internally, particularly our finance people, that there are opportunities that we can't see internally in terms of our program. Mm-hmm. Intuitive has a large data set, and not only locally, but regionally, nationally, and internationally. And they can help us better see opportunities that we may not see ourselves. We only see what we see. We only know what we know. So that partnership has really allowed us to find opportunities to decrease open surgery. Now, our philosophy is that, we're always going to have open surgery. We're always going to have laparoscopic surgery. But where it makes sense, we want to be able to offer robotic surgery to our clinicians and patients if it's the best choice for those particular cases.
Well, Dr. Martin, as you just described here, data in organizations, regardless of size, a lot of people touch that data. I'm curious, when you decided to pursue a data sharing agreement, can you talk more about that process and what, if any, key stakeholders you really needed to have important conversations with to get them on board?
Sure. When we were presented with the opportunity to move into a data sharing agreement with Intuitive, our biggest challenge was convincing our internal partners, particularly legal and finance, that this was actually a good thing to do. They had a number of questions around potentially PHI, financial data, how this data was going to be used, and whether there was going to be real benefit for us internally. We went back and forth. We had a number of discussions. We redlined a number of agreements. And we finally got them to understand that the opportunity for us to really look at our data in ways that we were not thinking about provided greater value for the program. We only see what we see. We only know what we know. Intuitive has a perspective that isn't only local and regional, but national and international. And therefore, this has provided real value in terms of our program. I think, again, I mentioned earlier that over the last 3 years, we've decreased our open surgeries, and we do about 40,000 a year, about 25,000 open surgeries a year by 10. And that conversion has gone from open to robotic. Our laparoscopic surgeries are flat. And so it really has been a tremendous value proposition for us through this data sharing partnership.
John, entering into a data sharing agreement at Methodist Dallas, was it a similar experience to what Dr. Martin described? Anything different you would note or add on?
Well, Dr. Martin and I may work for the same organization. Our people that are very well intentioned. I think maybe a lot of us in healthcare can relate that making sure that information is handled appropriately obviously is very important in any industry and of course in healthcare as well. So very similar experiences is Dr. Martin shared. You know, I think at Methodist, being in Dallas, Fort Worth, and every market's different. At the time when we started on our robotics journey several years ago, we believed entering into growing our robotics service line could be a strategic advantage for us, really around growth, probably primarily. And I think I heard Dr. Martin say earlier that he's kind of looking at case count early on. Well, full disclosure, that's really what I was looking for. I was looking to be competitive and attract surgeons to our hospital, and Intuitive and the Da Vinci robot seemed to be a pathway forward for us to grow as a health system. Very proud of our health system. That's really because of working with Intuitive and the work that they did to demonstrate to us that they were about more than just selling robots to us. We wanted to partner. They wanted to partner with us to make sure that our outcomes were improving as well. And so I think once we had enough time to convince everyone in legal and IT and finance that really the intent here was to make sure that we're sharing data appropriately to drive outcomes, right? To drive, as I mentioned earlier, the key metrics within what we call our quadruple aim in our care commitments at Methodist Health System. That was our intent. Then the doors began to open. And at Methodist, we are a fairly lean organization. Maybe all of us would say that we're lean in our organizations. But we didn't have, at the time, a very robust data team. And that's changed now. I think our relationship with Intuitive and I think Dr. Martin mentioned MACA, and I'm so proud that I know what MACA stands for now, but our market access and custom analytics agreement that we established with Intuitive really helped open doors to establishing our own more robust data team internally, where I know our end users now, our physicians, our robotic steering committee, our robotics coordinator who happens to be a nurse at our organization, they have direct access to this data. They get to see it first. They get to scrub it. And they're the ones that get to suggest and implement change based upon data that prior to entering to our agreements with Intuitive, we did not have actionable data.
Not necessarily flying blind, but perhaps not flying with as many insights into operations, finances, clinical outcomes. John, let me stay with you for one moment here, because I'm curious if there's anything else you would add about, we heard about the early steps of agreeing to these data sharing agreements, getting on board, but how has the level of insight changed over time? What data, are there any other data points you were regularly analyzing with before your work with Intuitive that now you analyze differently, or anything else you would add that you now have more clear and better insights into?
Oh, definitely. So bear with me. My wife calls me the Kenny Rogers of healthcare. I like to tell stories, right? I describe our journey like a funnel. So we started at the top of this funnel years ago. And when I say years ago, it hasn't been that long. In retrospect, I've been with Methodist Health System 10 years, and we've been on our robotics journey for maybe 7 to 8 years, I would say, really robustly on this robotics journey. But early on, it was just about being competitive, case count, and were we growing, right? Now, as I think about, okay, we're closer to the bottom of that funnel, and what specific information are we getting? And similar to, I think, what Dr. Martin and Nancy both said, we now focus upon each subspecialty, and we now know, right, and real time, essentially, in each subspecialty. So for colorectal, or for general surgery, or for urology, our foregut program, what percentage of those cases are done minimally invasive and open. And I think, as Dr. Martin said, our surgeons are very focused upon minimally invasive. They believe in many cases is best, because we now have the data to prove that. And it doesn't have to be all robotic. It can be, when appropriate, that they encourage cases to be done robotically based upon the data that we're seeing. Because once we are able to see minimally invasive, but by specialty, the number of cases or percent of cases done minimally invasive versus open, then we can start comparing length of stay between minimally invasive and open by specialty or subspecialty. Admission to ICUs, and an ICU bed, and this time that we've gone through over the past 1.5 to 2 years of surges during the pandemic. It's important that we're always protecting the critical resource of an inpatient bed, whether it be a medical surgical bed or an ICU bed. So now, with this data, we can better predict, based upon our past performance, open versus minimally invasive surgery, where patients tend to go. And we have data that shows minimally invasive procedures oftentimes do not take up a intensive care unit bed at Methodist Health System and at Methodist Dallas. Blood loss, discharge home same day of surgery, those are all key metrics that help us understand, from a quality standpoint, are patients getting better care with minimally invasive surgery. And then lastly, cost of care. It's very important that we have sustainable programs at Methodist Health System. And so we can see, from a contribution margin standpoint, and direct cost of care for a procedure, minimally invasive versus open, and the differences there. And by almost across all of our specialties, minimally invasive surgery outperforms open.
And so let's check in with you and better understand, within your group practice, who is involved in analyzing this data and how is it supporting the practice?
Well, being in the private practice world, not having the resources, obviously, of the huge data analytics teams and that sort of thing, but we did hire a clinical data analyst, if you will, to lead the charge of capturing and managing our initiative here, and that was critical. We actually tapped into the local universities for some statisticians and that sort. So, and they helped out too. But certainly the partnership with Intuitive and the depth and breadth of the complexity and things that we can do with not only our quality data of our unplanned events and complications and all those other things that I mentioned, that patient-reported outcomes, and marry that, combine that with the interoperative data. It tells a much more complete story and enables us, like the advantage of being in the private practice and our physicians practicing in multiple facilities, although each facility administrator doesn't like the fact that we do that, but it does then give us the opportunity to compare best practice. And if I've got one surgeon at one facility who is able to do things, and benchmark across the database that Intuitive has actually across the country, and we can, whether it's instrumentation, choreography, or even prescriptions that they're writing for that encounter, so on and so forth, and then try to marry that or copy that across all of our physicians and all of our different hospitals, I think it's a win-win. So that's the fun thing about having physicians and that practice in multiple facilities, and even multiple facilities that are in the same system, that you can see the variance, and then going back to those teams with Intuitive and their clinical folks that are in the OR, helping our surgeons get better at what they're doing to minimize their variation there, as well as the OR teams within the hospitals, and then our practice overall. So
I want to loop back, John, to something I think you and Dr. Martin alluded to, but perhaps we can part some wisdom with our attendees with us today. And that is just, obviously, data is a sensitive subject these days. and confidentiality is a very serious consideration. With that in mind, are there any parting words or best practices you would share with colleagues about gaining agreement within your organization to share data and have Intuitive's MACA team support with that analysis?
Sure. At Methodist, we didn't start with the idea of a MACA agreement up front. It was more probably a few years into our robotics journey. And thankfully, and maybe this really was more by design than I know now that I think about it, but thankfully we had started to build trust with our Intuitive team that was working with our hospital and our robotics program. Methodist Health System, we're 6 hospitals, so we're more than just one program that is at our flagship hospital here at Methodist Dallas. And in retrospect, Intuitive was what they were doing at my hospital. They were replicating at our other 3 or 4 hospitals within Methodist that have a robotics program. Actually, all 6 now to this, as of today, really do have some level of a robotics program. And, Intuitive already partnered with us to establish a robotic steering committee. So that helped build trust between our end users, hospital administration, our Genesis. We took advantage of the Genesis program within Intuitive that they offer that is really helping to come in and streamline operations, make improvements. As Dr. Martin talked about, really going into the OR as I envision it and helping the team that's touching the patient, right? How do they improve? And staff love that, right? Our doctors really embrace that process. And then lastly, the step that I think was the tipping point for really our system leadership to sign off on this data sharing agreement was a quarterly meeting that we established with our system leaders and each one of our hospital presidents that had a robotics program at the time. And probably after a few of those quarterly meetings, I think it started to sink in. And we invited key system leaders over finance, over legal, over these areas to those quarterly meetings. And over time, I think that involvement helped build the trust. Just like anything that you try to do is difficult. If you trust one another and you have a partner that is demonstrating that trust, it will help navigate the difficult waters of sharing very sensitive information.
Yes, Molly, just to expand on a couple of points that John was making, and one is around partnership. Intuitive has moved away from, and we have moved away from Intuitive just selling us robots to helping us develop solutions that are going to be beneficial to our customers and to their company. And I think that's imperative in terms of building the trust and being able to move on to combined solutions that help both stakeholders. In addition to that, it's about program. So this data sharing, we had, for example, as most places, some early adopters that were way out in front, and general surgery was lagging, thoracic surgery was lagging. This data really helps define opportunities that exist within the program that we may not see or may not have eyes on early. So partnership, programmatic development are key elements to really growing and leveraging the opportunity that minimally invasive surgery and robotic surgery provides.
Like you said, going from selling products to really offering services and solutions, Dr. Martin, that tees up my next question beautifully. I'm curious, now that you have so many strategic insights, how are you using it? How are you putting this to use for change management initiatives? How have you used benchmarking data to identify opportunities for standardization? I know Nancy mentioned that a bit with the surgeons in her practice, whether that be operational, strategic, financial. Nancy, can we check in with you first on this one?
I think initially, for sure, the data has given our practice the opportunity to come up with the best practices from a clinical perspective, which is then also operational. So I mentioned the ERAS protocol, in addition to not only the surgical approach as far as optimizing the patient preparedness and readiness for the surgery, and then quickly ambulating them and getting them out of the hospital as fast as possible as well. So it's sort of a combined effort, but it really has honed in all of the surgeons into much more similar care path, if you will, and adoption of how to take care of our operative patients. And so that has, again, not only within the OR itself, but also within the practice and how we engage our patients much earlier, getting them involved in the conversation at the time of scheduling, all the way through post-acute and what their home life is like, and then we're bringing in the social determinants and that sort of thing. So it's impacted us greatly as far as how we care for the patient, not just what's going on again in the OR in that hospital stay, but much more greater than that.
And Dr. Martin, how about your hospital? Because they call it change management for a reason. Sometimes change isn't always initially all that well received. How has this data helped usher in good initiatives for your organization for the better of patients, finances, operations?
Yeah, that's a great question. And for us, it really has enhanced our internal partnerships. Again, we have surgical groups that were operating in isolation, and even surgeons operating in isolation. So an example is we're looking at total cost of care of a robotics case versus a laparoscopic case versus an open case. But even within robotics, we're looking for the outliers. So if we've got a surgeon that's doing a robotic prostatectomy that's twice as expensive as his peers, we want to understand why that is. Sit down with him, point out the opportunities, and understand it. We're not prescriptive, but surgeons are very competitive. And when we shed light on sort of the outliers, they tend to move back towards the mean. So for us, it's provided a great opportunity to understand what instruments are being used, why they're being used, and more standardization. And my definition of standardization is rational variation. So where it makes sense to be different, we'll support that. But the vast majority of the time, just shedding light on the practices and the costs is enough to move those outliers back towards the mean.
Hey, Molly, can I add one thing to that?
Of course.
Yeah, Nancy and Dr. Martin have inspired me. So, I think our experience is after a while of having this information and this data, and really our surgeons scrubbing it, asking questions, pushing back, and now believing in the data. And it took us some time to get to that point where we believe the data that we were getting in our partnership through our MACA agreement. And I think that's a normal process, right? It's just understanding, is this data truly accurate, right? We gave it to, it's our data, but is it accurate? And so now, several years later, our robotic steering committee that is led by one of our bariatric surgeons, actually, he does a great job of working in advance of setting up the agenda. And I think to Dr. Martin's point, really, we've evolved to a point where, I'm just reminded that surgeons are competitive. And when shared appropriately, they like to look at their data. They like to compare themselves to others to see where those outliers are. Are they an outlier? And if so, what does that mean, and how can they improve? And kind of coincidentally, not just because Nancy's here, but I am very proud of our colorectal improvements at Methodist as well. And so just as a brief example, a few years ago, we had noticed over the data from about 2 years running showed that with our elective colorectal cases, as about 62% were being done robotically, 32% open, and then I think if I do my math right, that leaves about 6% laparoscopically. And so we were able to look by surgeon, who are the surgeons performing these surgeries, and identified, wow, we have a few that are making up a big percentage of that 62% that are being done robotically, and we have a few that are making up a big percentage of the 32% that are being done open. And we're able to compare their outcomes on length of stay, ICU admission versus a med surg bed, And again, we're trying to compare apples to apples. These are elective colorectal cases. And what we noticed with the open procedures, there was a big variation of length of stay of about 6 to 10 days length of stay, whereas our robotic elective colorectal procedures, the length of stay was more about 3.5 to 4 days. And so just having that information, and again, it took us some time to get there, but the doctors believing in the information really did help move the needle. And we've seen improvements because of this within the colorectal service line.
Well, Nancy, I think as John and Dr. Martin just mentioned, they're looking out for outliers themselves, but so are payers. So I wanted to check in with you about this side of the equation. Have you been able to use this data to negotiate with the payers by leveraging the outcomes that your surgeons who are using robotics are obtaining? And are there any strategies you use to engage payers in these discussions?
Yeah, that's an interesting question. That's like the Holy Grail, right? So yes, to an effect, but not as much as we would like. How about that? So the payers have all been presented with and they're aware of the data and our outcomes that our physicians are providing our patients clinical outcomes. And when, like John and Dr. Martin also had alluded to, you can put dollars to that, right? So the more minimally invasive, particularly robotic cases with the fewer complications and shorter length of stay and fewer unplanned events is ultimately going to reduce the total cost of care. So that is a story to tell, and it obviously can back it up with the data. There's always market dynamics that come into that. And depending on how mature a market is, as far as getting into some more of these value-based care arrangements, I think that's where our practice will be poised to do well. And when we get into these surgical bundles, our practice had already done that. We were one of the first groups that did do the lower biopsy bundle with Medicare or CMS. So we're familiar with what that looks like and what that process is, which is why I've alluded back to the importance of the total care coordination and the total picture and the data of all those phases of the patient's care, how important that is and the impact on cost. So I think as some of the integrated delivery systems that are assuming more risk and getting into more of these value-based care arrangements, we will be prepared and hopefully a preferred provider for these types of services. We are in discussions with some of the large employers as far as, because with colorectal specialty, the one thing that not only are we in the OR, obviously treating very sick patients, very complicated, bowel obstructions and that sort of thing, and colectomies, but we also do colon cancer screenings like the GI physicians are doing. So we are able to, from the outpatient service, preventive care story all the way into, down the care continuum. And so I think that is an interesting opportunity for employers to work with us on whether it's colonoscopy bundles on the outpatient and the anorectal cases, but then certainly on the larger, on the inpatient cases. And the data has enabled us to be able to be more predictive and understanding how our patients are going, where they're going and what the total costs are going to be. So when the payers and the ACOs and the other, organizations, whether employers directly even, are moving more towards those value-based care, arrangements, we are prepared and are actually pursuing those. The fee for service, yes. I mean, again, we can make some headway there, but I think in long term, that's not where it's going to take us.
Looking ahead, I'm glad you brought up employers too, Nancy. Well, as we wind down here, I'd like to go around and hear from each of you with your parting words of wisdom. Our topic today was leveraging actionable data for strategic decision-making and effective care team coordination. Dr. Martin, what piece of wisdom would you like to leave our attendees with today?
Well, I would say that it's important to be able to provide a robotic surgical approach where it makes sense. Most programs, you can get open procedure 24/7. You can get a laparoscopic procedure 24/7. You can get a robotic procedure Monday through Friday from 7 to 5 p.m. That's only about 28% of the week. You've invested in this technology. What other technology do you restrict to 28% of the week? So expanding access to off hours and weekends. And I'll tell you a story. With COVID, we were in this never-ending COVID service line now. One of the things that it afforded us to do, we had to reduce our inpatient surgical bed platform from 400 to 180 with the last surge. And what we did, so you could do as many outpatient cases as you wanted, but you were limited to inpatient surgical beds. But what we did find is that over the weekend, our hospital tends to empty out to some degree. And so what we did was expanded robotic cases to the weekends for cases with 24, 48, or 72-hour inpatient admission. We ended up doing several hundred additional cases over that quarter, helping us to keep our surgical volumes up while supporting the community and supporting our efforts around COVID. So expanding access is key. Also, one more quick story. We do a lot of transplants. We're doing a couple of hundred now donor nephrectomies robotically. We're doing recipient robotic cases. And a lot of those are not done during prime time. They're done off hours. So expanding access is key. Thank you.
Well said. Expanding access is key. Parting words from Dr. Martin. John, can we hear from you next?
Sure. Man, Dr. Martin's hard to follow. In addition to expanding access, I'd say involve your physicians and staff. That's been my big learning is that if there's any administrators that are participating today, you're probably way ahead of me, but it's just a continual reminder that when your end users, when your physicians who are using this technology, when your robotics coordinator, your circulators, the staff in the room, when they see the data, understand the data, participate in the process improvement, that's when the flywheel turns. You just get that engagement and makes things happen more quickly. And the sooner the end user believes the data, the more quickly things will move. So involve the people doing the work.
Involve those end users early and often. Nancy, what would you add to this running tally of wisdom?
I would echo and just add on to what John was saying as far as involving the physicians. Obviously, the surgeons are very instrumental or a piece of this whole puzzle. And I think it is a partnership. It's a three-way at a minimum with the intuitive capabilities, providing the data and the tools and the hospitals, but then also the physicians. I'm also a huge proponent of transparency. And even within our own practice, everybody sees everybody's results. They all get their report cards every month and every good, better, indifferent. And that's how you learn. It's, make it a more of a learned environment, not a punitive, right? So it's transparency, peer partnership. And then ultimately, how does it all tie to the patient, right? So we can be as efficient and as quick as we want to be and lean in the OR and in and out of the hospital, but how's the patient doing, right? What is the patient reported outcome? And we've really, really tried to always go back to that and what their activity level is like and what's their pain and are they better now than they were? And so keeping your eye on the patient in the middle in all of this as well.
Nancy, you said so much there, but I think one thing really important was that the cultural element of how there should be a culture of learning versus punishment, like you said. So well said, well summarized. John, Nancy, and Dr. Martin, we do have some questions from attendees that have rolled in. I would love to pose some of those to you for your thoughts. Dr. Martin, one related to something you had just spoken about, which was expanding access. This attendee would like to know, do you allow robotic surgery after hours on weekends? And if so, what data did you use to make that decision?
The answer is yes, we do. And the important point about expanding access is that the quality and outcome has to be the same. And so, for example, when we do cases on the weekends, we have a first assistant at the bedside, just like we do during the week. Nothing is any different on the weekends or evenings than it is during the week. We support them fully. And, again, what we looked at with COVID was really the thing that accelerated this change. we didn't have access to the inpatient bed platform. We had beds on the weekends. How can we leverage this opportunity to support patients in our practice? And we put a program together for weekend elective surgical cases, and that included robotic cases as well. And so as COVID waned, we continued the program. It's just part of what we do and who we are now.
Another attendee posed a question: if you're at the starting line, you're early on in your robotics journey, where would you recommend starting? Go ahead, Dr. Martin.
Yeah. So I'll say this: you start by taking a good look in the mirror, okay? And you ask yourself the question, where are you on a robotics program journey? Because most places, and even our program when I arrived, was individual surgeons doing robotic cases. There was not a robotic surgery program. There weren't KPIs. There wasn't good organization. There wasn't, who's in charge, what outcomes are we trying to seek? There wasn't all the stuff that we've talked about today. And so really I think the most important question is, where are you on that journey, right? And as you start walking down that road, once you get some distance, how are you going to determine how well you're doing? And so I'll stop there and let others, like John and Nancy, comment, but you got to take a good look in the mirror first.
No, that's great advice, Dr. Martin. And, I would just add understanding what your true north is, going back to what's the why behind why you're doing anything, right? And so when it comes to robotics and minimally invasive surgery, how does it align with what you're about? And again, sounding redundant, but our quadruple aim and our care commitments at Methodist does this service line. And now I say that naturally. I probably used to say, does our robotics program, but it truly is a service line. We've evolved to that point. Does it align with who we are and what's important to us? And matching that up, and then just get key people involved quickly, the right people to the table, along with Intuitive. You have to have that relationship with Intuitive. Look in the mirror, as Dr. Martin said, and understand maybe with your Intuitive partner, what's the trust level between the organization and Intuitive, and maybe making a list of quick wins, right? What is the biggest opportunity that your organization and Intuitive can achieve together to gain a little bit of momentum? It's easy, for me at least, to see all the problems, and it can become very overwhelming. But if you get the right people to the table with Intuitive and maybe identify those quick wins, that could help gain a little excitement and energy around starting the process.
Great advice. Anything you would add, Nancy?
No, if I think from more of from the individual physician or surgeon perspective, is also just to reach out to your peers, reach out to others that have already done it, right? And help, and they can help you, and what path did they take? And don't quit too soon. It is a particularly those physicians that are very, very efficient and very excellent laparoscopic surgeons, to convert and learn that this new tool, and it can be frustrating, and just to stick with it. And that's and the data will show them too. I think the data helps support, look, the outcomes that you're getting, at an early stage, even then, I think is helpful. But just stick with it and lean on your peers, and look for other best practices that have been very successful to model.
For attendees with us who are early on, take a good look in the mirror, as Dr. Martin said, as Dr. Phillips said, identify your true north, involve those end users and stakeholders early, identify some quick wins. And then Nancy, I think you summed it up really well. Don't quit too soon. A couple more questions. Let's get to these. We talked about data sharing agreements. An attendee would like to know, and this is kind of in the spirit of you don't know what you don't know, how did you identify the problems with the data you were working with pre-MACA, pre-Intuitive, and then who did you include in meetings to align and start making progress on goals?
I'll quickly try to address that without being too redundant. I just, at the time, looked at the data we had in our organization, looked at and knew what I had access to and what felt accurate that I could truly support if I put it in front of one of our physicians. And then looked at the information with Intuitive that we could get through our data sharing agreement, and some examples of other organizations that had gone before us, and just felt strongly that with better information, we could get to a better place with our care commitments and our achieving the key elements of our quadruple aim. And so for me, again, it was having the right Intuitive people at the table, along with the administrative leads of the other hospitals that had a robotics service line within their hospital, within Methodist Health System, and then 2 or 3 key corporate leaders. And these are all great people. I don't want legal, finance, or IT to get a bad rap today, but they're here to protect us, right, in the organizations that we serve. And so key leaders from those areas to be involved and talk directly to our Intuitive partners helped us tremendously.
Yeah, if I could just add one more thing to that, John, that's a great answer. And it helps quantitate the opportunity.
Yeah.
It's easy to have a discussion with the surgeon and say, hey, there's an opportunity to do more MIS colorectal surgery. But what does that mean? How does that translate? What do you mean more of an opportunity? Yeah. So the data really helps define what, where, how, and starts that discussion and gets you on the roadmap.
Yeah.
I'm glad you said that too, John. Those departments or leaders are just doing their job and with rigor as we would expect. So one other question from attending, this will be our final question. They would like to know, we talked about change management. They would like to know if there are any impactful focus areas with change management initiatives you would recommend they consider or pay attention to in their own efforts. Dr. Martin, can I get your thoughts here if you have them ready?
I'm thinking through that, and I'm thinking through sort of our journey. It's really about, I think, from our perspective, is engagement. So, you know, I have a perspective on what I think the program might be able to go. An individual surgeon or service line has a more limited perspective. How do we align on a common view, if you will? And then how do we begin to move people towards that? And that's the change management piece, right? People don't want you to move their cheese. Yeah. They're happy, as John mentioned or Nancy mentioned, a laparoscopic surgeon, you know, in my hands, this is the best approach, and I've been doing this way for 15 years, and why should I change? So trying to align the opportunities and to a lot of this is around peer-to-peer development as well. I can say this as much as I want to a surgeon, but if you get another surgeon who does the same type of work, who is talking about an opportunity, and we have the data, that really gets a person thinking, well, maybe there may be something here. So peer-to-peer discussions, associations, conversations, I think is really key for that change management piece from my perspective.
Yeah, you know, that this is a great question. It kind of stumps me a little bit. So thank you for Dr. Martin jumping out there and sharing initial thoughts. I think something that I could have done more of that I've identified in retrospect is early on in the process, asking the key stakeholders, the end users, questions. Maybe asking more questions instead of me assuming that I believe this data and this type of agreement or arrangement where we're going to share data, analyze it, was going to be good for them. Ask more questions about where they are, what they think is working, what isn't working within the service line, to identify there's some things that the people that are going to be impacted, that are going to have to do a lot of this work and be at the table, there's some things already that they want to do, that having a more robust data analytics platform can help them with what they're already struggling with. So instead of me assuming, you know, that I know what's best, right? I would ask more questions, and that seems to oftentimes get more buy-in early on, and that's could be effective.
And if I could add one last thing before we move to Nancy, and that is always understanding, what's in it for them, right?
Yeah.
We know what's in it for us,
Yeah.
but what's in it for them? Why should they make a change or consider making a change or consider doing any of this? And got to be able to answer that question.
Nancy, anything you would add to your co-panelists' thoughts so far?
And I think you're right. It is the peer-to-peer, which is inherently what we have, right, within our own private practice. And so it is just, but when I also say don't quit, I mean, it's a forever thing. It's, as I say, it's now the data's in our DNA. It's what we do. But it does get exhausting, all too. And so but it's a constant reinforcement, a constant, again, a much more of a learning environment where every month we have our reports and what we've done better and look at our different metrics. And if one looks way off over here for this individual, then the other surgeons, hey, what happened on that case? And so it's very conversational, but it's very peer-to-peer, and just a constant continuous effort. And I think with our new arrangement now that we have with MACA2 and the internal interoperative data that we never really had access to at this level across 30 surgeons and the comparative that we can do, they are really trying to get better at what they do. And without that data that Intuit has been able to provide within the OR, they can really learn from, they're really, really learning now what the different choreography is, the instrumentations and let alone the whole OR, time and turnover and the whole OR environment, learning from each other. And then again, as I said previously, and then how does that tie back to my patient outcome? And that's why we're doing it, right? So we want to be better at what we do so that the next time somebody picks up the phone or goes out on the internet and Googles colorectal surgeon or specialist, why us? Why would they pick you? And ultimately it's because you developed, you're providing the best care with the best outcome.
Nancy, Dr. Martin, John, I want to thank each of you for this dynamic discussion today. I learned so much about how you obtain data, what you watch and monitor, how you use it, and also, most importantly, how you use it to drive sound and strong decisions in your organizations and slowly but surely define the status quo. So thank you so much to our attendees as well for joining us for this important topic. And we wish you the very best in your experience throughout the other sessions today.